Good afternoon, everyone. I am Ann Wong with the Illinois Chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar on the business side of vaccines. Today we are joined by Becky Dolan from the American Academy of Pediatrics. Before we begin, I would just like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Becky will answer them at the end of the presentation. Afterwards, everybody will receive a link, an email with a link to the PowerPoint slides, a link to complete the evaluation in order to get your continuing education credit, and also a link to view the recording webinar. I'm now going to introduce Becky Dolan. Ms. Dolan holds a master's degree in public health education from Tulane University. She has spent the past 10 years at the American Academy of Pediatrics working in the Department of Practice on Coding, Private Payer, and Medicaid issues. She is a certified professional coder and a certified pediatric coder through the American Academy of Professional Coders. Prior to starting her work with the AAP, she spent over 10 years working in a private pediatric office where she worked in the front office coding and billing and was also a part of the clinical staff. Please join me in welcoming Becky Dolan.
Good afternoon, everyone. We are recording this today, so you'll get to see my lovely face throughout this presentation. We're just going to do a few things quickly here so I can see my slides, and then we will get started. But I thank you all for joining us. Can you get rid of this so I don't see it? There. Thank you. Just a quick disclosure, I have nothing to disclose. And I promise this will not hurt a bit, which is the lie we tell our patients as well. So why is it important to understand CPT and ICD coding? Well, it's important for a lot of reasons. It allows for increased and appropriate payment. It decreases provider and practice liability, and it also allows for information flow. So these three key components are very, very important in terms of being able to get your codes put in on time, the right codes put in on time, increasing your payment, and reducing any liability issues. So let's first take a look at our ICD-10 reporting. We are now moving into almost the third year of ICD-10, if you can believe that, and things have been going rather smoothly. So since I-9, we've really had some significant changes when it came to ICD-10 reporting. We used to have a number of codes in ICD-9 that would relate to the specific vaccine we were given. But when we switched to ICD-10, it was decided that only one code would be used, and I believe you're probably all familiar with the code, which is Z23. So for Z23, we report this for every vaccine encounter, regardless of why they are present that day, and regardless of what vaccines are given. So if the patient comes in for a well check, a preventive medicine service, you will still have to report the Z23, unlike the way it was in ICD-9. The same code you will also use for vaccines given during a sick encounter. Sorry about that. So let's take a quick look at this. A 10-year-old presents to their pediatrician for a bump on their left axilla. It's diagnosed as folliculitis. During the encounter, the pediatrician decides that they need their flu vaccine. The physician counsels on the vaccine, and it's given. So when we look at our ICD reporting, we're going to report the appropriate code for the folliculitis, which is the LO2.422, as well as the Z23. So same thing here. If a 4-month-old presents for their well child check, the baby is healthy, vaccines are ordered and given, you're going to report the Z00.129 in addition to your Z23. And in terms of vaccines, that pretty much sums up the ICD side of things at this point for vaccines that are given. So we're going to take a little switch here and go to CPT. We're going to start off looking at the Pediatric Immunization Administration codes, which I think by now we're very familiar with, but unfortunately we still have a lot of questions that come in and concerns regarding these codes. So let's just go through this as a reminder. The 90460 is immunization administration through 18 years of age. So yes, that does include 18 years, patients who are 18 years of age. Any route of administration, but also includes counseling by a physician or other qualified healthcare professional. And this is our first or only component for the vaccine that's administered. The 90461 is then for each additional component that we give at the same time within the same vaccine. So 90461 is added on to our 90460. We still get a lot of questions in on what's considered an other qualified healthcare professional. And remember, what I talk about here is the CPT definition. Some Medicaid plans may have their own, but anything that's going to stray from a CPT guideline should be received in writing. So a physician or qualified healthcare professional is an individual who by education, training, licensure, regulation, and facility privileging when it's applicable, who perform professional service within their scope of practice, who independently reports a professional service. And they are distinct from clinical staff. I bold that area because that's the most important piece of this whole thing. It's those who can independently report a professional service. I won't read clinical staff, but basically those are the staff that are unable to report independently, such as your registered nurses, LPNs. They are not considered qualified healthcare professional based on a CPT definition. Most people have gotten this area down, but I'm just going to reiterate what a component actually is. So it refers to each antigen in a vaccine that can prevent a disease caused by a single organism. Conjugates or adjuvants contained in a vaccine are not considered to be components. So let's take a look at that. So for our HPV, influenza, meningococcal, pneumonia, those are all single component vaccines regardless of how many valents they may have or how many strains they may protect against. It's still one component because it's a single organism disease. So just HPV, just influenza, just meningococcal. Now a TD would have two components. So you would report your 90460 and 90461 because we have your tetanus and your diphtheria. Those are two distinct organisms that cause a disease. The Tdap is a 3-component vaccine. So that is your diphtheria, your tetanus, as well as your pertussis, 3 different distinct organisms. So that'll be reported with the 90460 with 1 unit. I'm sorry, 90460 with 1 unit, excuse me, and 90461 with 2 units. And you can see that that trend goes down. The Pentacell and Pediarix are 5-component vaccines. So you'll see there you have your 90460 with 1 unit and your 90461 with 4 units. So let's take a look real quickly at this little chart I put together. So is the patient 18 years of age or younger? If you answer yes to that, you must also ask yourself, is there documented physician or other qualified healthcare professional counseling? If your answer is yes to that, you will report your 9046061 as appropriate. However, if you answer no to either of the questions being asked, you have to defer to the 90471 through 90474, codes that we'll be talking about in just a minute. So again, just to reiterate, if both of the criteria for reporting 90460, 90461 are not met, meaning the patient is 19 years or older, or there is no documented counseling. Now remember, we need both of those criteria to report the 90460. So if both are not met, we're going to report our what we call the non-age specific immunization administration, and that simply means that these codes are applicable to any patient at any age. They are set up quite differently than our component-based codes, but let's just remind ourselves what they are, because again, I just got a question in the other day about these codes, so I feel like we should go over them again. So 90471 is immunization administration for one vaccine for your first vaccine. That includes percutaneous, intradermal, sub-Q, IM. Your 90472 is each additional vaccine, percutaneous, intradermal, subcutaneous, IM. 90473 is your immunization administration by oral or intranasal route, one or only vaccine, or the first vaccine you're given. 90474 is each additional oral or intranasal vaccine. So the reporting instructions have been clarified in CPT, but there still seems to be a lot of confusion. So your add-on codes, your 90472 and 90474, are reported in addition to your primary code. So in this case, it could be a 90471 or a 90473. You will never report a 90471 in addition to a 90473, because even though there might be different routes of administration, you can never report more than one first or only code, which is the 90471 and 90473. So those two codes can never be reported together. You must use an add-on code once you've already reported a 71 or 73. Let's just look at the code distinctions side by side. So the 6061 codes, they require physician or counseling. The 71 through 74 do not. The 9046061 are not reported based on route of administration. They include all routes. The 71 through 74 are distinct based on route of administration. The 6061 can be reported per component. The 7174 cannot. They are reported per vaccine. And the 9046061 have a specific age requirement, while the 71 through 74 do not. So the physician and other qualified healthcare professional must document that counseling took place for each vaccine component. There are no hard and fast rules from CPT on this issue, but we offer up some general guidance. You should document that the parent or guardian did receive the vaccine information sheet, The risks and benefits of the vaccine components were discussed. Issues or concerns that were brought up by the parent were addressed. And your care plan over the next few days to deal with possible side effects for each of the components and when to call the office. Again, just to reiterate, this is just guidance that we have offered up. This is nothing required by CPT. But most payers are going to look for information like this when you are reporting the 6061. If your physician or qualified healthcare professional does not counsel on all vaccines given, then you cannot report the 6061 for all of them. You will only report the 6061 for those that they have counseled on. For vaccines that are not counseled on, always defer to the 90471 through 90474. And this is important here to remember. If you're going to be reporting a 90460 for a different vaccine that was counseled on, and then there's another vaccine that's not counseled on, you have to report the 72 or 74 in addition. You cannot report 90460 with 90471 or 90473. Those are all considered first vaccine administration codes. So for example, your physician counsels on an MMR, but not the annual influenza. So you're going to report your 90460 and 90461 with 2 units for your 3-component-based MMR, and you'll report the 90472 for the influenza because that was not counseled on. Also, very important to remember, we get this question in quite often. You can't report the counseling code, so the 9046061, if vaccines are not given on the same day. If the physician decides to counsel on an MMR but defers it for 2 weeks, maybe for an illness or mom asked to defer it, and they come back and see a nurse only, even though they counseled on it 2 weeks prior, you cannot use the 9046061 unless the counseling takes place on the same day the vaccine is given. So next, we're going to talk about vaccine products. Unless you're billing Medicaid for VFC vaccines, you're always going to report an administration code in addition to your product code. They are two distinct services and you should be paid for both. As a reminder, we find all of the vaccine product codes in the medicine section of the CPT manual, and they range from codes 90476 all the way up to 90749. And as vaccines are added, you're seeing a lot of resequenced, so you'll see a lot of a hashtag. That's not a cool new age thing, and it's just the way they show that vaccines are being resequenced in the CPT code set. These do identify the product only. They do not have anything to do with the administration. And this just lists a couple of codes for the common vaccines, 90700 for your DTaP, 90713 for your IPV, 90716 for the varicella, and the 90744 for your Hep B. Most of those you probably know and you could use them in your sleep. So just a reminder, vaccine product codes do come out twice a year. This is different from any other CPT code which only comes out in January. Again, this is really important to accommodate new vaccines that come on the market and that receive FDA approval. So codes that are posted on January 1st become effective the following July 1st. Codes posted on July 1st become effective the following January 1st. Vaccine product codes are often released before the vaccine is even on the market or has received FDA approval. If you see a vaccine code with a lightning bolt, it indicates a vaccine is pending FDA approval. I've listed below a link. You may want to bookmark this, and this is the AMA site for updated lists for vaccines. Feel free to utilize that as January approaches and we see new codes come out on the market. It is important to remember, very important to remember, that without FDA approval and the CDC's Advisory Committee for Immunization Practices, which we call ACIP, or AAP, AAFP, routine recommendations, and I can't stress routine enough, a vaccine will not be covered by most, if not every payer. So it's very important to also know the FDA approval as well as the ACIP recommendations for each vaccine. For more information, I've also included a couple links here. This is the CDC ACIP as well as the AAP Red Book, and the Red Book does list the recommendations as well. Typically they coincide, sometimes there's variations, but typically they coincide. So remember, with the product, you want to report the CPT code that most accurately identifies the vaccine product you are administering. You want to look at things like the product itself. Is it a combination versus a single component? The disease it targets, obviously, for example, Hep B. Dosing schedule. We have some vaccines on the market, same disease targeted, but different dosing schedule, a 2-dose or 3-dose vaccine. Chemical formulation, is it a polysaccharide or a conjugate? Route of administration, subcutaneous or is it IM? As well as, and this is very important for our influenza vaccines, is it a preservative or no preservative? And there are other things to consider as well. Remember, if you are doing a combination versus a single component vaccine, you must report the combination code and not list the individual components separately. CPT has done a nice job this year of deleting a lot of the individual components because they're no longer manufactured. So I don't think any longer we're going to be seeing the measles, mumps, and rubella as separate products. That should be deleting because they recognize those are no longer available on the market. So you're only going to see the MMR in the future. So with every year, we have vaccine product changes, new CPT codes, updates to the code set. Just as a quick reminder, we talked about this. Remember, if you see a lightning bolt, it's FDA approval pending. The dot is the new code, triangle is a revised code, and again, the hashtag is our resequenced code, and that is something you're going to see a lot in the vaccine product section. So let's just take a quick look now at our vaccine product updates for the 2017-2018 year. There was a slight change to our meningococcal vaccine code, and this is just to line up with the CDC abbreviation. Not much really changes there for us. But for the 90621, they did change it because they did approve it for a 2 or 3 dose schedule. So that has been added to the 90621 code. And just to piggyback on that, it's not new for this July, but it was new in January. They did the same thing for the HPV 9-valent code. They did add it because the ACIP recommendations came out in December to change that to a 2 or 3 dose schedule. So there was a lot of questions that came up when the HPV changed. So now the CPT code has been revised in January to note that it's 2 or 3 dose schedule for the 9-valent HPV. Another new influenza code. I feel like we have those every year. This is the 90756 code, and it's the influenza virus vaccine, quadrivalent, derived from cell cultures, subunit, antibiotic-free, 0.5 ml dosage for IM use. Now this is for the Flucelvax quadrivalent that's in the multi-dose. Because as you'll note, this differs from the other Flucelvax code in that it's not a preservative-free. So again, important to note this is an antibiotic-free antibiotic-free product, but it does contain a preservative because it's for the multi-dose. Now this code was published July 1. It is set to be implemented January 1. You're probably saying, oh, what if I get this in my influenza series coming up, so you might be giving it starting as early as August or September. Unfortunately, this is one of those things where you have to make sure your payer has this code loaded and ready to pay. They are not required to pay it before January 1 based on CPT implementation, but a lot of payers do preload it. So this is one where I would highly recommend if you do get this vaccine in, again, this is the Flucelvax quadrivalent multi-dose, you double check with your payers on the correct code. Some updates. The 2017-18 flu season will have vaccines that are both the quadrivalent form and trivalent. So again, it's very important to note which one you're given. While we're seeing less of the trivalent, they're still out there. So again, be very, very sure to report the appropriate code for the vaccine that's given. And once again, the flu mist is not being recommended by ACIP for the 2017-2018 flu season. And because ACIP isn't recommending it, it will most likely not be covered by most, if not all, payers. So again, with our influenza product, we want to ask ourselves, is it tri versus quad? Preservative versus no preservative? Is it antibiotic-free? And it's very important to also look at the age recommendations. The age recommendations for each vaccine, they're kind of all over the place. So it's important to make sure that that also matches up. This chart here, I won't really go through it, but this chart here does kind of give an outline of each of the vaccines that we are aware of at this point that are going to be available for this year's flu season. The corresponding CPT code, the descriptor, the manufacturer, and the brand. These are not listed in any order other than the CPT code. We don't endorse one over the other. And also the recommended age. So if you'll see there's asterisks on a few of them. These age recommendations have changed since last year. So it's important to note that the fluvaval quadrivalent, that is now for greater than or equal to 6 months. They changed the trivalent Afluria to now be greater than or equal to 5 years. The FDA had approved it that way, but ACIP had not. ACIP has now changed their recommendations. The double asterisk notes new vaccines for this year. We have a flu block, the Afluria quadrivalent. So I know this isn't a flu webinar necessarily, but just wanted to make you guys aware of what those mean and what's going to be new on the market. So you make sure that your CPT codes are all matching up and that you have the right CPT codes loaded based on the specific vaccine products that you have in your office. But again, we do get a lot of questions about the recommended ages, so just make sure that you're in line with what ACIP recommends. And again, these age recommendations also come from the CDC for VFC purposes. So some changes to the flu recommendations for this year. Once again, I just want to reiterate about the live influenza virus, which is the intranasal one. It is once again not being recommended. I do believe the product is available, but again, it's not being recommended, so we highly suggest not ordering it. Again, we talked about a couple new vaccines that were new vaccine products that were licensed for the 17-18. The Afluria quadrivalent and the flu block. These are for patients who are 18 years and older, so not very prevalent in pediatrics, but if you have a multi-specialty clinic or you see kiddos who are older. Again, we mentioned, in addition to fluvaval, the quadrivalent, which is from GSK, is now licensed for children greater than or equal to 6 months of age, which came down from the greater than or equal to 3 years of age. And again, the ACIP now recommends use of Afluria for persons over 5 years, greater than or equal to 5 years of age. And again, this is in line with the FDA's licensure. Throughout the presentation, I do talk a lot about vaccine product coverage because this is very important. You all pay for these vaccines most often, especially for private payers, and you want to ensure that when you're giving them, they are covered. So again, I cannot stress enough, without FDA approval, routine vaccines given will not be covered. It's very important that you ensure that everything you're doing does line up with CDC, ACIP recommendations, or AAP. Recommendations do follow, so the recommendations that come out from ACIP or AAP will follow FDA approval. So the vaccine has to be approved first by the FDA, and then it will go into the queue to be the recommendations to be published. The time between FDA approval and released recommendations can take some time. That is one of the biggest killers for us, is when a vaccine comes on the market and it's being marketed and it's a great vaccine, but they have yet to release the ACIP recommendations, you're kind of stuck. So unless a payer specifically comes out and says, we're not concerned about ACIP recommendations, we're going to follow what the FDA says and we will start covering it, without that in writing, it is best to wait unless you're going to have the families pay for the vaccine up front, which can be very costly. Again, if you are routinely vaccinating someone, be sure that you are following the routine recommendations. I cannot stress that enough when it comes to coverage, because payers do adhere to these recommendations very closely. You don't necessarily have to be able to read this slide, but it's just kind of something I wanted to show you all. This is the HPV recommendation straight from the ACIP website. And there is a lot of information you're going to see when you click on a recommendation, and you really are only going to need to see this part right here, right where the words say recommendations. They will list the recommendations typically based on routine and catch-up age groups, talk about dosing schedules, they'll talk about persons vaccinated previously, interrupted schedules, and special populations. There's other different topics too they address, but this is what's under HPV. So it's important to become familiar with these because recommendations do change. The HPV vaccine's been on the market quite a while now, but these recommendations were updated in December. So it's important that you click on each of the recommendations, which are found again on the link I shared earlier, the CDC ACIP recommendations. and you just want to scroll down to the topic of recommendations. The rest of that, your doctors can read, but as coders and as people who are going to be billing these codes out, you need to be able to know what the recommendations read, especially if you're denied. If you're denied and what you're showing is within the recommendations, this is your argument here because they will be following these recommendations. So I know you're not going to be able to sit here and read all this. You don't need to. I just kind of wanted to give you an idea of where on a published recommendation you'll find this, and it does use the word recommendations, and it's found usually about halfway down. So again, when you look at vaccine product coverage, you got to look at a couple different things. Is the product FDA approved? Yes, it is. Do we have published ACIP AAP recommendations? Yes, we do. Are you giving the vaccine in compliance with FDA approval and ACIP and AAP recommendations? If you answer yes to that, you should not be receiving denials from your payers. So in mentioning earlier, we talked about the new HPV recommendations. Again, those came out in December. And this has to do, again, this is really a coverage issue because we've seen some issues with this throughout the year. So if a person's initiating vaccinations before the 15th birthday, the recommended immunization schedule is only 2 doses. For persons initiating vaccination on or after their 15th birthday, the recommended immunization schedule is 3 doses. So again, these are the things you want to keep in mind as you're vaccinating your kids for the HPV, because payers will look to these recommendations in terms of coverage. So now that we've talked about the vaccine being FDA approved, ACIP recommended, you're giving it within the ACIP recommendations, now we're going to talk a little bit about vaccine product payment. Now payments for vaccines can vary. They vary from practice to practice. They vary from region to region. But all of these payments should also be included in your contracts. Typically what happens is your contract will stipulate how you're paid for the vaccine. But the payment for the product, and again, this is just the product, not the administration. It should cover the payment you paid for the vaccine product itself. We highly recommend you refer to the CDC private sector dosing cost. The link is provided for you there. They update this quite frequently, so I advise you can actually sign up for updates. They'll shoot you an email and say, hey, we've updated the vaccine price list. It should also take into account the personal costs for ordering and inventory, storage costs, insurance that you have to pay against the loss of vaccines, recovery of costs attributable to inventory shrinkage, wastage, and non-payment. This can be when a patient refuses a vaccine after it's drawn up. And lost opportunity costs. So you're maintaining a very large inventory of very expensive vaccines. So it should also take into account the fact that you are now storing very costly vaccines and it's lost opportunity. The payments for vaccine products must be free of any discounts and based on a transparent and verifiable data source. So one of the most commonly used data sources is the CDC private sector cost dosing, which is what I explained and shared with you on the previous slide. Cover the vaccine product purchase price as well as related office expenses as noted in the last slide, and a little return on investment for the dollars that have been invested in this. And be at least 125% of the current CDC vaccine price list for the private sector. Again, refer you back to the CDC website that I shared previously. Now, if you find that your payments are below these rates, be sure to check in your contracts. And you have to check them with all of your payers. Unfortunately, this stuff is usually hidden within each of your contracts. Make sure they are paying what was negotiated on in your contract. If they are, and you are still receiving payments that are low, use this information we've provided you when it's time to renegotiate your contract. Remind the payers that these indirect costs are not taken into account with the vaccine administration codes. Those have their own separate services built into those. So we touched briefly on when vaccines are not given. It's one of the reasons why we ask for payment to include that. Let's talk about a little bit about vaccinations not carried out in terms of people who may just refuse them or you can't give them for some reason. So ICD-10 does contain a whole list of codes that allow the physician to report vaccines that have not been administered. These are reported as secondary codes, but unfortunately they are not specific to show which vaccine was not given. That's the one issue we have with the change to ICD-10. So it was great we don't have all those I-9 codes to show the need for prophylactic vaccination against X disease. The problem is that it limits us to be able to tell the payer which vaccine was not carried out. We're only able to tell them why something was not carried out, not which one. Because oftentimes it's not all vaccines that are not being given, but maybe one or two. Here's the list here of all of them that are not carried out for reasons of acute illness, chronic illness, caregiver patient refusal, patient has already had the disease, or other reason. We did add this year to other reason when a manufacturer may be delayed in shipping, if there was a product issue delay. That has been added to the Z28.89. It just clarifies that that's where that issue would go. If the vaccine is on back order, it's not necessarily for, oops, we forgot to order. It's really for the times where we have a vaccine shortage. So that's just a way to track what's happening with that vaccine. So for example, we have a 12-month-old patient who presents for a well child exam and vaccines. Patient contracted the chicken pox at 10 months of age. Patient does receive the Hep A and MMR, but not the varicella. So we're going to report our 99392. We're going to link it to our ZOO.129 for a healthy infant, Z23 because they came in also for vaccines, as well as Z28.81. A vaccination is not carried out because patient already had disease. Then you're going to list your corresponding MMR, Hep A, and the vaccine administration codes. And you're going to link each of those to your Z23. Now again, this brings up the issue of what vaccine wasn't given. So unfortunately, we can't be specific in that realm, but at least this is a way to track that a vaccine was not given because the patient already had a disease. It's not a perfect system, but it's what we have for now, and we're working on ways to fix that. Let's look at another vaccines not carried out encounter. A 13-month-old presents for a routine well child exam. The parents are informed that the child will need an MMR and varicella. The mom refuses, stating she believes both vaccines are harmful and would like her child to be older. Despite counseling, she still refuses. So the pediatrician is going to report the 99392 and link it to ZOO.129. Again, encounter for vaccines, Z23 because they came in for that, and Z28.82, vaccines not carried out because of caregiver refusal. Now, unfortunately, with the way the codes are written, we cannot add on the counseling component. That's not something we can code for separately. It is built into the 99392. So one of the concerns that we have with not being able to show that a particular vaccine is given is the HPV is being tracked in the HEDIS measures, and that's a concern that many of our practices are having for showing that a patient or parent refused the vaccine or for some other reason the HPV could not be given. So again, like I mentioned, we are concerned about that as well, and we want to be able to help alleviate that issue, but it's still a work in progress on how we're going to be able to rectify that issue. Another issue that comes up very often is the vaccine is drawn up, mom gives consent, and then they decide not to get the vaccines. So they're counseled, they agree, you drop the vaccine, bring it to the room, and the patient or parent decides they don't want them or the child is so out of control it's just not safe to give it. So what are your options? Are you simply out the money? Is that why we're asking for more payment when the other vaccine products are given because of waste? So one thing we do recommend is preparing for these situations in advance. Check your payer contracts. Contact legal advice about drafting an office policy that says the parent or patient is responsible for those costs if you're not able to give that vaccine. And also to know some coding options that you may have for that particular vaccine, that situation. But again, keeping in mind that we do fight and advocate for vaccine payment above and beyond to count for this wastage that may happen. Some payers do allow for payment when the product code is submitted with the JW modifier. Another option for your ICD side is your under immunization status code. These are for patients who are behind on their vaccines, continue to be behind, or on a lapsed immunization schedule. It's more of a status code to indicate that we understand, we recognize this patient is behind on their vaccines, and that's the Z28.3 code. And use it as appropriate, because a lot of times this is where some issues can come up and you want to be able to show the payer that we understand the patient is behind. We're doing the best we can. We recognize it. Either mom or dad are refusing. Patient's been chronically ill. There's some other reasons why this patient is behind. So let's take a look now at immunization administration and evaluation and management services, or your office visits. We'll be discussing your quote-unquote sick office visits, not preventive medicine services. Those are a little different. But this is really for the cases where a patient may come in for vaccines or be in for a sick visit and need vaccines. You have to remember that the E&M service or your office visit must be significant and separately identifiable. The appropriate E&M service code should be reported in addition to the vaccine administration and product codes. Modifier 25 is required when reporting a problem visit, such as a 99213, in addition to your administration. It should not be required when reporting a preventive medicine service, but unfortunately Medicare and Medicaid does not agree with that, and they do require the 25 modifier on the preventive medicine services. And most payers have picked up on this. So it is important that you are billing modifier 25 on any sick, so a 99213, for example, and any preventive when you're also billing for vaccine administration codes. If you're doing a well sick, modifier 25 goes on both. And we always have to remind people that if you're going to use modifier 25, you have to remember what it means. It's defined as a significant and separately identifiable E&M service by the same physician on the same day as a procedure or other service. So in this case, your vaccine administration. The service performed in the E&M should be above and beyond the other service provided and substantiated by documentation that satisfies the criteria that's needed to report that E&M service. As always, it should be medically indicated and necessary. So we get a lot of questions about vaccine-only encounters. So the patient walks in the door for the sole purpose of vaccines. This can be very common during flu season. This is also very common when a patient may need a second or third HPV. If the vaccine is the only thing that is addressed and nothing else is brought up, you will code only for the vaccine administration and the vaccine product. We're going to talk a little bit about this later on in terms of Illinois Medicaid, but this is the rule in general for other than Illinois Medicaid. You do not report an E&M service for vaccine-only visits unless the service meets the criteria for using modifier 25. We get asked all the time about 99211. We all know that is our quote-unquote nurse visit. It doesn't require any specific key components. So when a patient sees the nurse only for immunizations, when should a 99211 be reported? And this is in addition to the vaccine product and the administration. Again, this excludes Illinois Medicaid. So we got to take a look real quickly at what is included in administration codes. Administrative staff services such as making the appointment, preparing the chart, billing, and filing, and clinical staff services such as greeting the patient, taking routine vital signs, obtaining a vaccine history, getting the vaccine information sheet, answering routine questions, preparing and administering the vaccine, and observing for any immediate reaction. That's what's included in the vaccine administration codes. So all of those services are not reported under a 99211. So when can it be appropriate? Well, again, the service must be medically necessary. The service must be separate and distinct and significant from the administration. And the nurse must evaluate, manage, and document the significant and separate complaint or problems unrelated to the actual administration of the vaccine. So in terms of documentation, you need to always do the date of service and reason, or your chief complaint. That's always required. A brief history, any exam elements, a brief assessment or plan, along with any counseling or patient education, and signatures of the nurse and supervising physician. Again, must be all unrelated to the vaccine administration. So I mentioned a couple times this excludes Illinois Medicaid because Illinois Medicaid has their own rules on this. They do take exception, but private payers do not. Under Illinois Medicaid, it states that reimbursement for the practice expense of administering the injection is included in the office visit when the client sees a practitioner. If the client comes in solely for an injection, the CPT code for a minimal level office, E&M, not requiring the presence of a physician, so also known as the 99211, may be submitted to cover the practice expense. The specific vaccine procedure code is to be submitted to cover the cost of the vaccine or the cost of obtaining it through VFC. Seasonal flu vaccines also follow these guidelines. So that's very different from private payers. Briefly going to mention modifier 33. This has been out for quite a while now. The use of it is intermittent, kind of all over the place by payers. But we notice that if there's issues with coverage for preventive services, including vaccines, this modifier has been helpful in reducing the cost sharing issue and coverage for preventive related services, including vaccines. But again, these are vaccines that are routinely recommended by ICAAP. That's something that needs to be followed. So we're going to talk quickly on when not to report IA codes, which kind of sounds silly, but there are times and people are very confused on this issue. So when we give an immune globulin, those are not vaccines. Those are usually prophylactic injections, which are different from a vaccine. For example, the RSV or Synagis, that is not a vaccine, that's an immune globulin. The vaccine, or the code, the product code is 90378. It's reported per 50 milligrams. And your 96372 is your administration code. Remember, it's not a vaccine, so we do not use the vaccine administration codes. The immune globulin product codes are found between 90281 and 90399. That's the best way to identify it's an immune globulin and not a vaccine. The PPD, we get this a lot. In fact, we just had a practice audited for reporting the 90471 to administer a TB test, and they have to repay back all that money. Remember, 86580 does take into account administration. You cannot report a 96372 or a separate vaccine administration code in addition. The 86580 is it. The ACA also requires that state Medicaid programs implement the NCCI edits. In 2013, a new edit came out bundling all IA codes and all E&M services, including preventive medicine services. Without using modifier 25 on your E&M service when billing IA codes, one service was being denied. Since Illinois Medicaid does not pay on IA codes, this was not an issue for Medicaid. However, some private payers are following. And in fact, at this point, most private payers are following. So again, it's just in your best interest to use that modifier 25. Modifier SL, this is reported with a vaccine when the vaccine is state supplied. This is one that's required for HPVs. The provider is not enrolled in a VFC program. And this will allow you to be paid for the cost of the vaccine. And this is particularly for the HPV vaccine if you are not a VFC provider. This is really for informational purposes only. Trying to go through what the National Drug Code is and how it looks is a little cumbersome, but I wanted to share this information because we are seeing more and more and more and more payers that require the National Drug Code. It was never meant to be used for vaccines because vaccines are a little different than other medications that are out there on the market. But unfortunately, a lot of payers have misinterpreted it and now use it for vaccines. The HIPAA standard requires 11 digits, not 10. So it's important if your product comes in with a 10-digit, we do need to make sure it's 11 digits when it goes out to the payer. So some of the products only list 10. We need to bill out with 11. So these give you some examples of how the segments break down. It's all products that are reported by the same manufacturer will all have the same first numbers. Then you'll have a product code and a package code. You also have to check with the payer. Sometimes they want the code if it's a multi-dose box. They want the product code that's on the box, and sometimes they want it on the vial. Again, very confusing and cumbersome for simple vaccines, but it's important to know your payer preferences on that. So again, this just kind of talks about what happens when you have a 10-digit product code and you need to convert it over into an 11-digit product code. So I just want you all to have a couple examples of how that works. Again, this continues to talk about the 11-digit versus the 10-digit. So let's get into some coding options here. This is really talking about the difference in the vaccine administration codes, and I feel like I talk about this every year, but every year we still get a lot of questions in on it, so I feel like we need to continue educating. So we have a patient or a parent who is counseled by a physician on 2 single component vaccines. The physician gives the vaccines. Patient is 18 years or younger. So what vaccine codes are we reporting for this one? We're reporting our 90460 with 2 units. Same here, 2 single component vaccines. Physician counsels, but the nurse gives the vaccines. Patient is 18 years or younger. Same coding. Doesn't matter who administers, so long as the physician or other qualified healthcare professional is counseling. And again, I need to remind you this is also for private payers, not Illinois Medicaid. All right, so the patient or parent is counseled by a physician on a single component vaccine. The vaccine is given. Patient is 19 years old. So we're going to be reporting the 90461 or the 90473 for an oral or intranasal. Because the patient is 19 years old, even though there's counseling, we cannot report the 60. Next example, a patient or parent is counseled by a physician or qualified healthcare professional on 1 multiple component vaccine. The physician or qualified healthcare professional gives the vaccine. Patient is 19 years old. Again, we are at 90471, and that is it. Because the patient is 19 years old, this 90460 and 61 cannot be reported. 90471 through 74 do not take into account components, so our only option is the 90471. The patient or parent are not counseled on 2 multi-component vaccines. Both are injectables. Patient is 5 years old. 90471 for the first and 90472 for the second. Even though the patient does meet the age criteria, counseling is not performed, so we cannot use our 90460. Patient or parent are counseled by the nurse, say an RN, on 2 multi-component vaccines. Again, both are injectable. Patient is 5. Same exact answer. Even though the patient meets the age criteria, the counseling is done by clinical staff, and therefore it does not meet the criteria for the counseling. Unfortunately, RNs, as qualified as they are, do not meet the CPT criteria. Excuse me. The patient or parent are counseled on 2 vaccines, part of a well-child check. Because the patient is sick, the physician has them return in 2 weeks for shots only. When they return, the patient only sees the nurse. So the counseling takes place at the well-child check, but they come back and see a nurse only. So what codes are reported for the counseling? Unfortunately, nothing separate for that. And again, the 90471 through 74 is reported for their administration upon their return. The patient or parent is counseled on a 3-component vaccine. Given the same day are 2 single-component vaccines where no counseling is done. Patient is 1 year old. So here we're going to report the 90460 and 61 with 2 units for the component vaccine, the 3-component vaccine that was counseled on, and our 90472 for times 2 for the ones that were not counseled on. Remember, we can't report the 71 with the 60. All right, just a couple of vignettes for Illinois Medicaid. This is only Illinois Medicaid. An established patient presents for her 13-year-old well check. She has never received her HPV, physician counsels, and it's given. The 99394 is the preventive medicine service. And the 90649SL is the product code for Gardasil, which is submitted for the payment for the administration. Same patient returns 6 weeks later for the second Gardasil, sees a nurse only, or a physician, doesn't matter, for the injection. Again, here we can report the 99211 minimal office visit plus the 90649 SL. I'm not going to go through these vignettes, but these really offer up some ideas on the vaccine specific coding and modifier use. And a lot of this has to do with NCCI edits. So you'll see a lot of 59s on the 96161 for the maternal depression screen because there's an edit with the 90460. Remember, the E&M services, including preventive medicine, needs modifier 25 when we also have the vaccine administration codes. So these are really for example purposes and modifier use. If you see a code in red like that, those are just HEDIS recommendations. It has to do with certain HEDIS recommendations for the age group. So those are optional codes depending on if you do or do not follow HEDIS. And this is just for your review after all is said and done. These next few slides just go over some of our resources. Again, on the NDC, more information on Illinois Medicaid and billing for vaccines. The Academy has a lot of resources as well. The National Academy has a lot of vaccine resources, the coding table, the FAQ, influenza implementation guidance. This is a huge resource. It's not just coding, but it's everything related to influenza. And again, for the business cases for pricing vaccines, immunization administration, the vaccine addendums, this is important. This is a great link and resource for private payer advocacy, so if you do need to go back and advocate for payment. So I think that wraps it up with a few minutes to spare. Thank you very much. I apologize for some of the chaos here and the phone ringing. But I think we're done with that portion.
All right, thank you so much for that. We are now, I think we have a couple minutes left where we can go over the question and answer portion really quick. So I will go ahead and take a look at what questions we have. Let's see. So what do we do about Illinois MCOs that are not paying CHIP vaccines correctly?
So the question is about Illinois MCOs that are not paying CHIP vaccines correctly. So I'm assuming these are people who don't qualify for VFC. Again, we have to check contracts. That's the number one thing we have to look at. What are they paying on? Are they paying on the CDC private sector cost? Are they paying on average wholesale prices, which is the AWP? Are they paying on the average retail price? You have to look at that first. If they're not paying at least what you're paying, you need to let the academy know. I would highly, highly recommend you contact the academy. We do have a coding hotline email that we can always send out to all the attendees today, along with the slides if they're going to get a copy of those. And you can let the academy know. We do advocate for payment and we do talk with payers, but unfortunately we do need to look at your contracts as well.
Okay, and then another question is, any advice on NDC codes? Some plans don't pay for vaccines without it.
That's a trend we're starting to see more and more is the NDC. So hopefully I gave you some resources here. If you have specific payers where you're having, sometimes it's a little tricky, let us know, because again, sometimes they want the vial and sometimes they want the box. It can be very confusing. But if you, again, email the academy, we can always help you navigate what a particular payer wants. Unfortunately, we wish they didn't do that, but they can.
Okay, and then when you say exclude Illinois Medicaid, does this include the managed cares?
I believe it does exclude them. I believe this is just Illinois fee-for-service, but double check the link I sent you, which is from the Illinois handbook. So I believe, but again, that will depend. If the MCOs are paying on vaccine administration and they're paying on the vaccine product code, then I'm going to say they follow the private payer rule and not the Illinois Medicaid rule.
Okay, and then the last question that I have is, can we not report the vaccine CPT code with a zero charge and diagnosis vaccine?
So that's something you got to check with your payers on. There's a couple reasons why we don't recommend that. And one, they might put the CPT code in their system to make it seem like they've already received it. And two, they also may not allow a zero charge to go out. I know I've seen that with some payers and or clearinghouses. So if you put it with a penny and they pay you that, it could be considered fraud. So I would highly suggest before you ever do that, you talk to your payers at that point.
Okay, awesome. I think we've about wrapped it up. So I'm just going to quickly go over a couple points. I've gotten a lot of questions about whether or not you are receiving the PowerPoint slides. And like I said at the beginning of the webinar, everyone is receiving a copy of them. You should get an email by the end of business day tomorrow or Monday that has a copy of the slides, a link to complete the evaluation, a link to the recording of the webinar, and everyone has to complete the evaluation by July 28th, 2017. If you do not complete it by that day, you will not be eligible to receive continuing education credit for this, and nurses and physicians will be receiving credit. And then lastly, you will receive a copy of your certificate by August 14th. If you don't receive your certificate yet and it's not August 14th, please do not send an email asking about it. Everybody will get it by August 14th. So thank you so much to everyone for participating in this webinar. We have many other webinars that we host, and we hope to see everybody at one of those in the future. Thank you so much. And thank you again, Ms. Dolan.